The Senior Rehab Podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join. Hit me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults. Shorts. This is Senior Rehab Shorts, the evidence-based segment for geriatric rehab clinicians, bringing you relevant and applicable content to better serve your patients, regardless of your setting. And now your host, Joe Daniels.
Hello, friends, and welcome to another episode of Shorts. This week's article comes out of GeriNotes from Volume 24, Number 1 from 2017. And it is by Rick Ward, who's a PT, a geriatric clinical specialist, and a certified wound specialist out of Texas Women's University, who has been practicing in the acute care setting for 21 years and is currently a senior acute care PT at Wise Health Systems in Decatur, Texas. Can be reached at rward@wisehealthsystem.com. And his article is titled, Challenged and Changed in Acute Care PT Through Evidence-Based Practice. And I really enjoyed reading this article and his thoughts and his reflections from attending a CEEAA course recently and how that's impacted his practice. So without further ado, here's the article. When you've been a therapist for any length of time, it's very easy to become complacent and settle into practice patterns that are comfortable and predictable. This can happen in any setting, but I've found that to be especially true in my 21 years of acute care practice. Busy patient loads, documentation demands, case management issues, staff supervision, and student supervision can often affect your personal and professional development and limit your growth as a therapist. Despite being an effective therapist providing quality care, I've always thought I could be better and incorporate the evidence-based strategies I've seen in my continuing education courses and in the literature. When I've used my continuing education over the years to further my knowledge of geriatric physical therapy, the implementation of the things I've learned was difficult, and I'd often find myself returning to comfortable practice patterns that I had used prior. However, this past year, while taking the CEEAA course, which is the Certified Exercise Expert for the Aging Adult, through the Academy of Geriatric Physical Therapy of the APTA, it all clicked. I realized that thinking in terms of evidence-based practice is not only possible, but can change the entire way that you practice. The CEEAA course is a 3-weekend course focusing on the literature and the evidence related to functional outcome measures and exercise prescription for geriatric patients. While it is impossible to condense 6 days of information into simple concepts, my take-home messages from the course were as follows. 1. The use of functional outcome measures is essential for quality patient care. And 2. As therapists, we do not exercise our geriatric patients at a high enough intensity to see significant changes in muscle performance and aerobic capacity. The use of functional outcome measures in the acute care setting can be challenging given the patient population, the length of stay, and finding an appropriate measure. But I realized that even using simple measures like gait speed, 5-time sit to stand, and single leg stance test can provide a wealth of information that objectifies my assessment and discharge plan, guides my treatment strategies, and provides baseline information for other therapists as the patient progresses in their continuum of care. I recently evaluated a patient in the hospital who was admitted with pneumonia and debility. This patient is a 75-year-old female who lives by herself but has family that lives nearby and checks on her daily. She reported that she'd been feeling weaker over the past few weeks and has been using a rolling walker since that time, although she did not previously use any assistive devices. She denied any incidents of falls in the past 3 months, but stated she did not feel confident without her walker at this time. The results of the evaluation were as follows. Independent in bed mobility, modified independent with transfers, gait distance of 250 feet with a rolling walker with O2 sats at 98% on room air, gait speed of 0.5 meters per second, 5 times sit to stand, 20 seconds, single leg stance test, 10 seconds on the right leg and 8 seconds on the left. Although her mobility assessment showed minimal deficits, the functional outcome measures revealed significant deficits in community ambulation ability, i.e. slow gait speed, functional strength with the 5 times sit to stand, and balance with the single leg stance test that make her a high fall risk. I now have objective, evidence-based data that can be used in conjunction with my subjective clinical judgment to provide treatment in the acute care setting, as well as providing justification for further physical therapy treatment with home health or outpatient on discharge from the hospital. By focusing on functional measures, my practice has improved in significant ways, impacting both efficacy and outcomes. My documentation has changed to include specific, evidence-based justification for my clinical decisions. My treatments are now guided by measurable data from functional tests that validate the interventions needed to enhance patient function, independence, and safety. My patient education includes explanations on normative data from these same functional tests that help the patient better understand the risks and the benefits related to their function and lifestyle. My practice has also changed by the realization that as physical therapists, we can have a greater impact on our patient's function, a greater impact on our patient's strength, in addition to balance, more so than we ever would have thought. The evidence is clear that our geriatric patients can see significant improvements in all these areas, but it is also clear that the intensity of our prescription must be high enough to stimulate those changes. The common phrase used throughout the CEEAA course was, "You can't change a system if you don't challenge a system." We are the experts in exercise prescription for balance, flexibility, gait training, muscle performance, and aerobic capacity testing. I've become more committed to the use of prescriptive resistance for strength training, designing targeted system challenges for balance training, and providing sufficient intensities for aerobic capacity training so that the patient is challenged effectively to result in significant functional gains. So just as our patients can make significant changes in function when therapists provide the appropriate challenge, the same changes can happen to us as our careers progress. By focusing my practice on evidence-based patterns, I've challenged my skills as a therapist, and I've seen significant improvements in the way that I practice. I would encourage all of you who work with geriatric clients to task yourselves in optimizing your resources available through the literature, the internet, and continue in education to provide the most effective and appropriate treatment to your patients. We are the experts in movement and exercise. As we continue to become more proficient and efficacious in the care we deliver, our role and contribution to the healthcare community is strengthened. So some powerful stuff there by Rick Ward. Like I said, I really enjoyed reading that article and just, how he was able to implement some of the things that he learned into his immediate practice patterns. So that was really neat. So in terms of next week, there is a systematic review that I'll be discussing that I am really excited to dive into. Similar to the previous evidence-based segment, but more geared towards the community dwelling older adult. A lot of heavy hitters and names behind this paper, titled Determining Risk of Falls in Community Dwelling Older Adults, a Systematic Review and Meta-Analysis Using Post-Test Probability. So again, this is going to be some really strong content there and a lot of powerful take-home messages for community dwelling folks. And even though those aren't the folks that most of us are working with, definitely still relevant information. So until next week, stay funky, my friends.
Hit me. Thank you for listening to the Senior Rehab Podcast. I appreciate your time. And if you enjoyed this episode, do me one favor. Share it with one other person that would benefit. Thank you. If you want to see the show notes or find more episodes, just go to seniorrehabproject.com. And until next time, my friends, do not forget to stay funky. The Senior Rehab podcast is sponsored by Great Seminars and Books. If you need high-quality geriatric con ed that's worth your time and money, check out Great. Owned by the living legend Carol Lewis, Great offers courses and products created by recognized leaders in geriatrics. Learn the most effective techniques for diagnosing and treating your patients. Just go to seniorrehabproject.com/great and get $25 off by using the code SRP25. The show is also sponsored by you, the listener. Go to seniorrehabproject.com/join to find out how you can help steer the direction of this movement and join our monthly meetup. Once again, that is seniorrehabproject.com/join.